Aiming for Success. My name is Leila Valinsky. I'm a Senior Program Administrator and the New England Regional Lead for the Quality Payment Program work for the New England Quality Innovation Network Quality Improvement Organization. I'm very proud to be working with the Massachusetts Health and Hospital Association for this presentation today. We hope that you were able to join us last Monday when we covered merit-based incentive payment system reporting. And just as a reminder, last week's presentation as well as today's will be available for the recordings as well as the slides should you have missed any portion of today's presentation. Your lines are muted. At the end of the presentation, we will open the lines up for questions. You can also always enter your questions in chat. A brief disclaimer, my organization, the New England Quinn QIO, is a CMS contractor. All of the content today is pulled from CMS materials. However, these slides were created by us. A brief overview of what I'll cover today. We'll talk a little about alternative payment models, or APMs, the APM scoring standards and the variations to the APM scoring standard, performance categories and the scoring methodology, efficiency and engagement, public reporting, resources, and then, as I mentioned, questions at the end. As many of you know, CMS loves to use acronyms. We see acronyms pretty much all throughout the program. A few that you'll hear pretty frequently today are APM, which is Alternative Payment Model, CMS, the Centers for Medicare and Medicaid Services, EHR, Electronic Health Record, MACRA, Medicare Access and CHIP Reauthorization Act, MIPS we'll just touch on briefly is the Merit-Based Incentive Payment System, QPP is the Quality Payment Program, EC, Eligible Clinician, and Advancing Care Information and ACI. So, MACRA, the Medicare Access and CHIP Reauthorization Act, was finalized in April of 2015, and the final rule was released in October of 2016. Through MACRA, the Sustainable Growth Rate formula was repealed, and the Quality Payment Program was created. Under the Quality Payment Program, there are two payment tracks, MIPS, which is the Merit-Based Incentive Payment System, and Alternative Payment Models, or APMs. Again, today we will be focusing on alternative payment models strictly. Now, under alternative payment models, there's actually also two tracks. The first are MIPS APMs. Now, those are APMs that do not take on downside risk. They only take on the cost savings afforded to CMS. They also receive preferential MIPS scoring under the APM scoring standard. And we'll talk more about that scoring standard. And clinicians in these MIPS APMs receive a payment adjustment similar to those clinicians reporting to the MIPS program, where they would receive up to 4% positive payment adjustment based on quality. Now, those are clinicians in Medicare Savings Track 1 program. If you can see at the bottom of the blue column, advanced APM participants, which we'll talk about in just a second, if they don't meet the qualifying participant threshold, which we'll talk about on the next slide, they have the opportunity to report under the MIPS APM route. Advanced APMs take on both upside and downside risk sharing. So if the APM doesn't perform to a high enough extent, they would receive a penalty. If they do perform at a high enough extent, they would take on some of that cost savings and get a return from CMS. Advanced APMs are excluded from MIPS, and eligible clinicians under those qualifying participant groups would be eligible for a 5% lump sum incentive. Now, advanced APMs are Medicare Shared Savings Tracks 2 and 3, Next Generation ACOs, Comprehensive Primary Care Plus model, the End-Stage Renal Disease model, and Oncology Care model. That's for 2017. 2018 program year and beyond, there will be additional advanced APM models. The biggest one for next year, 2018, is the Medicare Shared Savings Track 1 Plus. That's a variation on the Track 1 that will take on the downside risk, similar to Tracks 2 and 3. Under the advanced APM route, qualifying participant determination must be calculated. So the qualifying APM participant's determination is made at the advanced APM entity level. So if you think of the APM entity as the house, so that's the structure, within the house are all of the practices that make up that APM, and those could be considered the rooms within the house. So this determination is across the board. If every APM within the entity meets the threshold, then the whole entity would meet the threshold. So how is the threshold calculated? The threshold score is determined by measuring both claim and patient volume. The determination period goes from January 1st to August 31st, and in the case of this year, it's 2017. If any of you are familiar with some of the CMS documentation, they did release, I think it was back in June, a predictive model which looked at claims from January 1st to August 31st of 2016. And based on that kind of old data, CMS is predicting that pretty much 100% of all advanced APM participants will be considered qualifying participants for this year. So let's talk a little more about how that threshold is calculated. So for the cost or the claims threshold, CMS will look at the payment amount. So the dollar value of Medicare Part B professional claims to those attributed beneficiaries within the APM over the total dollar value of those Medicare Part B professional service claims for the attribution eligible beneficiaries. So we could talk probably for a full hour all about attributed patients and beneficiaries and that algorithm. Really, it's looking at the patients that had services furnished by clinicians within the ACO. You have to meet certain dollar values to have patients attributed to you, but it's looking at those attribution eligible patients with the attributed patients over it, so divided by attributed patient. Now that threshold percentage score must be at least 25% in order to be considered a qualifying participant. If you only have 20% of your APM claims through that APM, there's another partially qualified APM participant, which we'll talk about in a second. If you look at the claim patient count method, the number of attributed patients, again, we talked about attribution eligible and attributed patients. You take the number of attributed patients through those Medicare Part B claims over the number of attribution eligible patients, again, looking at your Medicare Part B claims, and you divide that. Now, the threshold score for the patient count method must be 20% of your patient volume through the advanced APM. So 25% claims, 20% patient volume, whichever one you score higher in. So let's say you have 18% patient volume, but 27% claims, you would still meet the qualifying participant threshold, and your APM entity would be considered an advanced APM qualifying participant entity. Now, as I mentioned, if you have fewer than the threshold percentages, so if you have fewer than 20% of the claims and fewer than 10% of the patient volume, your APM would be considered a partially qualified advanced APM. And under a partially qualified advanced APM, you have the option to report. And that might sound kind of funny. CMS typically doesn't give you the option to report without offering up a penalty if you choose not to. This partially qualified group, in fact, is lucky enough. They have the option. If they choose to report, they follow the MIPS APM scoring methodology. So that's where I had that little asterisk. If you don't meet the advanced APM qualifying participant threshold, you have the choice to report as a MIPS APM. Now, if you choose not to report, you don't get any penalty, but you're also not eligible for any sort of incentive. So depending on if you're looking to get some money in for your performance, you either may want to report via the MIPS APM or not. It's really up to you. That's very confusing. The numbers get very crazy, but based on CMS's early predictions, all advanced APM models will be considered qualifying APM participants this year. As I mentioned earlier, for those considered qualifying participants in an advanced APM, you will receive a 5% lump sum payment. Now, that's 5% of the prior year's Medicare Part B covered professional services. That payment model will stay the same between 2019 and 2024. 2026 and beyond, qualifying participants will receive a slightly higher update to their physician fee schedule. That's 0.75% increase. We talk about this a lot. If you've worked with us previously, APM participation, this is sort of a joke. Check, double check, triple check, I'm getting tongue-tied, your APM participant list. As you can see, all of these dates have already passed. These are the 3 snapshot dates. CMS looks at the APM participant list to determine who is considered a part of the APM and thus falls under the APM entity and that APM scoring standard. So eligible clinicians who are not part of the APM participant list on that final snapshot date, which was August 31st, so about a little over 2 weeks ago, they must report MIPS as their own individual or under a group, however they're broken up from that APM. If a clinician was part of an APM, let's say up until August 1st and then left, again, they'd have to report MIPS. If you're new to a practice coming in, let's say you don't join until this week, maybe today's your first day, Monday, you would still need to report MIPS on your own. However, if you left another APM entity, let's say the last day you furnished services for them was last Friday, so on September 15th, you would actually be included under that previous APM participant list because you're still on their list as of August 31st. So you would be pulled into their APM and wouldn't have to do additional reporting. We hear lots of questions about eligibility, so it can be a little confusing. There is a MIPS participation status check tool. If you go to the qpp.cms.gov website, the link is there on the slide. You will come to that MIPS getting tongue-tied again today, participation status check tool, where you would enter the 10-digit NPI number and click Check Now. It will give you an update as to whether that clinician is either eligible or ineligible for reporting. The only thing about that is if that clinician happens to be part of an advanced alternative payment model or even a MIPS APM, it won't tell you that. So you would need to know whether that clinician is on the participation list or not. The check tool doesn't provide that information, so that won't help you. However, something very interesting that you will get information on is the special status determination. So this screenshot is from slightly lower down on that same page, looking at an MPI. As you can see, there's several special statuses that clinician and that practice might be designated as. So the first is not patient-facing. The second is hospital-based. If you are a non-patient-facing or hospital-based clinician, you are actually automatically excluded from reporting the advancing care information performance category information. So CMS made the determination that those clinicians oftentimes don't have adequate access to an EHR, or they don't have control over what that EHR does, so they would be excluded. Also, if you are a nurse practitioner, physician assistant, clinical nurse specialist, or certified registered nurse anesthetist, you are also automatically excluded from reporting on the advancing care information category. Now, we'll talk about the scoring standard in a minute, but your group still might have to report. If you're a small practice or a rural practice, that really won't help you much in terms of the alternative payment model, but you can see that information below. As you can see, there's also for the practice, so there's the clinician side and then there's the practice side. In order for a practice to be considered non-patient facing, 75% or more of their eligible clinicians must be considered non-patient facing. And for hospital-based, 100% of the eligible clinicians within that group have to be considered hospital-based. So we'll talk about the scoring standards. For a MIPS APM, and this holds true for all MIPS APMs, the quality category accounts for 50% of your score. We'll talk more about how it's all broken out in the measures, but that's reported via the APM entity. Advancing care information is reported by participant TIN. So if you remember, I said the APM entity is the house, the participant TIN is the room. So each of those participant TINs, which would be a practice, would be reporting advancing care information data on their own. You would get a weighted score based on the number of eligible clinicians within your practice, and that score then is aggregated up to the APM entity for an aggregate score. Luckily, if you're part of an APM, you automatically get full credit this year for your participation in that APM for the improvement activity category. So that's MIPS APMs. Those are the Medicare Shared Savings, typically the Medicare Shared Savings Track 1 ACOs. MIPS APMs that are non-MSSP. So this is a little confusing. As I'd mentioned, advanced APMs include the Comprehensive Primary Care Plus model, end-stage renal disease, and oncology care models. However, they fall into this MIPS APM scoring standard. So they actually don't have to report anything to quality. They get automatic credit for their quality reporting, and they would just follow the requirements based on their CMS contract. So quality is 0% for them. Advancing care information jumps pretty rapidly with this group. So it becomes 75% of their score. So in getting 75%, this group has the option to either report that participant TIN level data or individual eligible clinician. Now, some of you might be scratching your head, as we often do when we work with these groups, thinking, why would you ever want to report individual clinician data versus the TIN where you're aggregating all of your clinicians' data together? Honestly, that's a determination that you would make, but if you're looking to reduce administrative burden, I would say go the participant TIN method. This group gets 25% of their score from improvement activities, and just like the standard MIPS APM, they get full credit for participation in an APM. Now, advanced APMs under the Medicare Shared Savings Program, so that's Track 2 and 3, much like their fellow MIPS APM counterparts, they get 50% of their score from quality. Again, that's reported at the APM entity level. Advancing care information is 30% of their score reported by participant TIN for that weighted average that's then aggregated up to the APM entity level. And improvement activity is 20%, they get full credit for the APM participation. Those participating in a next generation ACO, so the advanced APM group, they also get 50% of their score from quality. That is still reported through the APM entity level. They do have to report advancing care information data, and that is still 30% of their score. Much like the MIPS APM non-MSSP track, they have the option to report either participant TIN or individual eligible clinician. Depending on how they report, CMS will take the best possible score for them, and that will become the APM entity's score. So a little bit of different method for aggregating their data, but still reporting advancing care information. Improvement activities remain 20%, and again, they get full credit for being participants in the APM. So quality. For all of the APMs, except for those in the MIPS APM non-MSSP track, any data that they're submitting is submit at the APM entity level, and they get one single aggregate score. The data is submitted by the entity through the CMS web interface for a full calendar year. We'll talk about the measures in just a moment, but those are 15 clinical quality measures, and they have a very heavy primary care focus. Most of these alternative payment models kind of were bred out of primary care, so that's why some specialists might think this really doesn't apply to me. And you're right, it wasn't initially intended to include specialists, so it's been a slow move towards including specialists. Unlike the MIPS program, for those of you who are familiar with that, this group can earn up to 110 points. 11 of the 15 measures are scored, and much like the MIPS quality measures, you can earn 3 to 10 decile performance points based on whatever your actual performance is. You have the opportunity to earn bonus points because you will be reporting on some additional outcomes, or actually additional high priority measures, so you get 1 point for those. If you report directly out of your EHR, so if you're able to pull data straight from your EHR and submit that to the CMS web interface, you can also earn some bonus points for that EHR end-to-end reporting. So these are the 15 quality measures. Much of them probably look very familiar to you: medication reconciliation, fall screening, the influenza immunization, pneumococcal vaccinations, BMI, body mass index screening and follow-up, tobacco use screening and cessation intervention, screening for clinical depression and follow-up, colorectal cancer screening, breast cancer screening, statin therapy for prevention and treatment of cardiovascular disease, depression remission at 12 months. Now, this one's a very interesting measure. If you look across this line, so it's fourth from the bottom in that blue, it's a high priority measure. However, there's no benchmark and it's not scored. So that's one of the 15 that isn't actually part of your score. The ACOs we've talked to, surprisingly enough, say that they have very small populations of patients that fall into this population for this measure. So the way CMS calculates the quality measures, so every ACO or APM group has their attributed patients based on all of those patients. CMS will provide roughly 600, a little over 600 patients per measure or measure set. Some of those get kind of combined together. And then the ACO must report 248 consecutive patients. So in that list of patients, they literally go down the list, 1, 2, and pull the data. Now, if you have fewer than 248 eligible patients, you would be required to report on all of the patients within your sample. And for some of these ACOs we've been working with, that sample might be as few as 4 patients. 1, 2, 3, 4. Literally, that's all they have in their sample, which seems kind of foolish since that's really not determining good care because the sample's so small. So maybe some work to do on that measure. There's the hemoglobin A1C, poor control, and diabetes eye exam. Those are composite measures. So whatever your score is for both of those measures combined, that is your score for that composite couple. Again, you can get 3 to 10 points for that. Hypertension, controlling high blood pressure, and ischemic vascular disease, use of aspirin or other antithrombotics. So as you can see, very primary care focused. Some opportunities for those cardiovascular physicians, but overall, really it's primary care. So for advancing care information, as I mentioned, all of the APM models, so every single model, whether it's Medicare Shared Savings, Next Generation, Comprehensive Primary Care Plus, end-stage renal disease or oncology care, you're all reporting advancing care information, which are those meaningful use measures. How are you utilizing and optimizing the use of your electronic health record? So each APM entity receives a single aggregate score. No matter how the actual score is derived, you get one single score. For the MSSP, APM participants, again, that's a weighted TIN average. So all of those participant TINs get a weighted average based on the number of eligible clinicians within the TIN that is then aggregated to the overall APM entity. For Next Generation and the non-MSSP participants, they can either report via participant TIN or individual eligible clinician. And again, those scores are taken the best of whichever method they select, and they're given an overall aggregated APM entity score. For this category, there's a couple interesting options. So clinicians and practices must report for no less than 90 days. Now, let's take a large ACO of 30 plus practices. Those 30 plus practices each can choose a 90-day period all their own. They don't have to select the same 90-day period. It's really whatever works best for them, but they must start no later than October 2nd. So that's coming up in just about 2 weeks from now. So if they haven't determined their 90-day period, that must start no later than October 2nd. Also, there's several submission methods that can be selected. All of those participant TINs can also select any submission method that they want. So 5 could use attestation, 5 could use EHR Direct, 5 could use registry, and the remaining 15, if they were large enough, could use the CMS web interface. Now again, that's only for groups of greater than 25 eligible clinicians. If you're thinking you want to use EHR Direct or registry, I highly recommend that you speak to your EHR vendor. We have heard that many EHR vendors are unable to support the EHR direct method, or second piece of that is they do have a cost associated with that, so check to see what's available within your system. The other is if you're considering registry or qualified clinical data registry, which is QCDR, make sure you speak to that registry to ensure that whatever measures you're planning on reporting are supported. Not every registry has the option to use this, so just make sure you talk to them. You'll also want to check because there is sometimes a cost associated with registry use. Usually that's a couple $100 per clinician. So see what makes sense for your practice and go from there. Same measures apply to the MIPS program, so that's the same 4 to 5 base required measures based on the certification year of your electronic health records. Depending on how you perform with those, if you meet the requirement, you have the option to report on 7 to 9 performance measures. Again, that's based on the certification year of your EHR. And then if you really want to go for the max points, you have the option to earn some bonus points, either reporting to a public health or clinical data registry, or, which we got clarification on recently, while all of the APM models don't need to submit data for the improvement activity performance category, if you do have activities in place, and that would be for 90 days, that support the use of your EHR. So that could be improving utilization of a portal or including patient-reported outcomes into your EHR. You could take credit for that additional 10 bonus percentage points for improvement activities that utilize a certified EHR. And if you have questions about that, we're happy to help you. As I mentioned, improvement activities do not require any additional data submission. You will receive full credit for improvement activity submission. So I'm going to talk a little about each performance category, except for improvement activities, because there really isn't much for you to do. But these are just sort of some of the tips and tricks and how to ensure that you have what you need to have in place for your program's plan. So for APM entities, again, quality is submit via the CMS web interface, and that's based on the attributed patient list that is given to the APM. Now, we hear oftentimes an ACO leadership member say, don't worry about quality. The ACO will take care of it for you. And I can tell you off the bat that that is a very risky proposition for you, because when a clinician hears that, we've got it taken care of for you, they immediately think, you know what, I don't need to do anything. And unfortunately, that's really not the case. So when you think about quality, while the APM entity might pull the data and submit the data for those clinicians are still expected to follow workflows to support the documentation and then reporting on all of those 15 clinical quality measures that I mentioned before. So again, think about, we've got it taken care of for you. Maybe try rewording that to, we'll take care of reporting for you, but you need to make sure you're still performing at a high level and following the designated workflow. So as I mentioned, talk about reporting. So do the participants even know how the data is pulled or where it comes from? How do they monitor their own performance? Do they know how to get those reports? As I mentioned as well, do participants know the workflows they even need to do to support reporting? Oftentimes for those specialists in particular, they might not even know what they need to do to document a pneumococcal vaccination. They might not know what buttons they need to click to say that they've assessed the patient for tobacco use and then provided the cessation counseling. So make sure you're working with all of your participants to give them the support, the workflows, the tools to monitor their performance and ensure they're doing what they need to do. And then finally, have you talked to your participants about what your performance expectations are? One would assume, much like in school, everyone wants to get at least or at max out at 100%, but do your clinicians know what you expect of them? Do you accept just sort of making it where they're doing the bare minimum, or do you expect them to excel and meet the thresholds, or not thresholds, but meet the performance levels at a high point? Advancing care information, again, this causes a lot of confusion across the board. So data submit by that participant TIN or individual clinician. It's really, really important for all of the APM leadership to communicate with their participants how that data is to be submitted. So even when we say participant TIN, if all participants within the APM are on a shared medical record, the APM might be able to submit all that data for the participant TIN. Or that participant TIN might need to submit it on their own. So communicate how participants are supposed to submit data, what the expectations are, and then how is that APM going to assist participants, or are they responsible on their own? Participant TIN and individual eligible clinicians, their scores, while aggregated and maximized, still affect that APM entity score. So do you have non-reporters? And by non-reporters, I mean those clinicians on paper. If you have an entire practice on paper, well, their score is going to be 0. If you have only a handful of clinicians, let's say you have a TIN that's spread across a couple different locations, and only a handful of those clinicians are on paper. In fact, they don't harm you and they don't help you. They're just a non. They don't provide anything to your score. It'd be 0. 0 in the numerator, 0 in the denominator. So know where your non-reporters are and what you can do to support them. Also, as I mentioned, the special status designated clinicians, are they excluded? So one, do you have just a handful of clinicians within each TIN that are excluded, or is an entire TIN excluded because it is all special status designated clinicians? So it's really important to know where you stand. We have worked with several practices who have very complex situations with clinicians they've looked up on the CMS QPP website that in fact they can't find data on. If that's the case, I would highly recommend you contact CMS. Oftentimes that's a disconnect between the CMS reporting on the back end and the PECOS website, that's PECOS. And it's really imperative that you connect those dots and make sure everything lines up. But check your clinicians. If you have any hesitation, something doesn't feel right, we like to talk about the gut check. So let's say we had this happen just the other day. So a practice of about 15 clinicians, the person we've been working with at the ACO side actually looked at all of the 15 clinicians. Pretty much all of them are being listed as non-patient facing. However, she knows for a fact that they see patients. I think they were an internal medicine practice. In that case, you might question that reporting from CMS. So CMS looks at old claims. That determination period for what you'd be looking at on the QPP website right now would be September 1st of 2015 through August 31st of 2016. So as you can imagine, that's over a year old now. CMS is in the process of running a second determination period check. So that will be September 1st of 2016 through August 31st of 2017. And they do put on a 60-day claims run-out period because claims take a little while to process. But be sure you're checking and that the data you're utilizing is the most up-to-date possible. And again, if something just doesn't feel right or look right, go back to CMS, connect the dots, make sure everything lines up. And then again, just like with quality, do participants know the workflows they need to do, and do they know what the performance expectations are? If you say, you know what, it's okay that you're not reporting this year, we'll take the 0, that's a risky proposition that they probably will continue for subsequent years. It's better to say, you know what, try to report the best you can and meet the base measures. Whatever your performance is, at least if you can meet the base measures, you'll get 50% of the advancing care information score. 50% is way better than 0. I wanted to talk a little about increased efficiency. So these are some fun buzzwords we hear a lot throughout healthcare. So population health management. What does that really mean? And how do you make that part of your practice and really impact patients and the healthcare that you're providing? So under population health management, there's a couple things you can think about. The first is chronic disease management. So looking at your patients with diabetes or COPD or congestive heart failure, how are you managing their care? Typically, those patients are the high utilizers and they cost a lot to care for them because they're in and out of the hospital. Their medications and testing is expensive, and they're utilizing a lot of the primary care physician's time. So when thinking about that, maybe consider the use of care coordination programs or practice transformation programs. How are you ensuring those patients have access to the care they need that hopefully is not hospital-related care, that you can manage in a meaningful way, and those patients feel like they're living the most out of life? So the next is practice transformation. Under practice transformation, this would be increased patient and family engagement, which we'll talk about in a couple more slides. And through this, you really want your patients to be engaged in their care, right? That's easy to say. I'm a nurse by training. I know that patients, it's a great idea to get patients involved. They either want to be involved or they don't. The same with family members. They either want to be involved or they don't. But maybe try to figure out ways to include them a little more. And we'll talk about that in just a couple slides. In practice transformation, it's also really important to use data to support why you're doing whatever you're doing. So use data analytics if you have access to it. See where your high costs are. See where maybe your patient satisfaction scores are poor. See where there's waste in your process and how you can improve care across the continuum. I don't know if you have hospitals or primary care practices or imaging centers, but look and see where you could cut out any sort of waste. The next important element is aligning efforts across risk-based contracts. So many alternative payment models and organizations, those organizations have contracts with multiple payers and other organizations, and they all require reporting on data. And unfortunately, many of those programs don't line up. So they all want slightly different data for slightly different populations for slightly different time frames. So clinicians feel extremely burdened by all this because every time they turn around, they're being asked to report on one more thing or check one more box or ask one more question. So see if there's a way that you can consolidate these quality improvement initiatives. While the populations might be slightly different, is there a way to roll a process out across the board for all patients? So maybe that's depression screening. Don't limit it to certain ages. Well, obviously don't do it for small children, but at that 12 and up range, just mandate it across the board for all physicals. And that way it's kind of ingrained into the clinician's practice. They all are used to it. They know how to conduct the assessments, and they know how to handle results that are abnormal. Again, this reduces the burden on clinicians, and talk to clinicians. Figure out where they feel overburdened and see if you can reduce those burdens. So, reducing the burdens for clinicians. How do you get provider and clinician engagement? If you don't have engaged clinicians, I can tell you right now, all of these efforts to perform at a high rate really get much more challenging because you need the clinicians on the front line to do the work and to be engaged in the care. So the first thing that you can do, you can ensure that there's consistent and frequent communication of performance outcomes. So are you, like I said, are you actually providing these clinicians with reports of how they're performing? Do they know if they're underperforming or maybe they're a high performer? Give them some credit for where they're really doing well. Offer those clinicians a place at the table talking about quality and practice transformation. It's really important to have those clinicians have a voice and allow them the opportunity to be heard. And kind of along those same lines, identify a clinician practice champion. So in all the work you're doing, it's really important to have a clinician who's actually engaged in this work and maybe is the one to pilot a change, to say, okay, does this make sense in my practice? And if it makes sense in my practice, can it be rolled out across the organization? Or maybe does it need a couple tweaks? And then it can be rolled out across the organization. So really identifying what makes the most sense. And then implement changes to your documentation system and workflows based on practice flow and time management. Think about how patients enter the practice, check in, wait, get roomed, have their visit, check out, get their paperwork. Like, what does that all look like? And when you start to add different documentation requirements or quality improvement initiatives, think about where they fit in the best manner possible And again, don't overburden your clinicians and staff and providers, because that will not make a successful program. And finally, as I talked about utilization rates and cost containment, discuss the dollars and cents of providing care to your patient population. Look at those quality and resource use or QRUR reports to say, this is where we're performing really well and our costs are contained and we're below what CMS has as a national average, or this is where our costs are really high and we need to actually work on reducing those costs. And hopefully, if you can intertwine all of those different elements, you'll have engaged providers and clinicians. Much like the providers and clinicians, you want to have engaged patients and family members. So how do you get to engage patients and family members? Utilize patient-reported outcomes. So when you put the onus back on the patients or the family members caring for those patients, they really do have a sense of ownership, right? They are now expected to provide you with data about the care of their loved one or of themselves. And if they have to provide you with data, they have to take a role in getting you the data. Employ shared decision-making practices into considering tests and procedures. Have the conversation with your patient about what's going on. Patients oftentimes will say yes to a procedure that maybe they have no idea really why they're getting it done. So if you can use shared decision-making where you talk about the benefits and risks, costs, potential outcomes, what the patient thinks about all of it, you'll get a highly engaged patient because they're being involved in the practice and the planning. Again, offer opportunities for patients and family members to take an active role in care planning. Bring them to the table. If you have patients that maybe are nearing the end of life, have the conversations with the patients and their family members about what those end of life decisions should be. How do they want to be cared for? If something comes up, do they want to be admitted, or do they want to try to stay in the home or in a hospice facility? Figure out what means the most to that patient or family member. And then, of course, provide personalized educational materials and programs. So here at the QuinnQIO, we offer a really great diabetes self-management program. While it's not necessarily exactly personalized to a patient, patients come together. So the 6-week program, patients come together and they share experiences and what maybe has occurred in their life. And through this 6-week bonding process, you see some really amazing relationships develop. And those patients take really meaningful information and steps on how to manage their care better from those classes, because they've developed these friendships and this level of camaraderie with their other patients and now friends, hopefully. So provide education that's meaningful to the patient and can be actionable. And then, of course, offer patients multiple methods of communicating with their care team. So I mentioned using a portal. Portals are great. You can get a lot of points through the Advancing Care Information category by utilizing a portal. Through the portal, you can obviously dump patient education materials, medications, allergies, problem list data. Patients can do secure messaging with their clinician. They can ask for refills. They can schedule appointments. If you have the opportunity, employ telemedicine, especially for those patients and family members out in the rural practices where maybe it's harder to get to appointments. Even patients, honestly, in urban areas, if they have any sort of mobility issues or financial constraints around transportation, offering telemedicine might be a great opportunity where they can interface with their clinician or a member of the care team and get the information they need, perhaps to avoid a hospitalization without having to leave the home. And of course, when they come to the practice, as we just talked about with all the other topics, spend the time doing the face-to-face interaction. So shared decision-making, talking about care planning, and then using patient-reported outcomes. I just briefly want to touch on public reporting. This is a pretty big deal. We don't talk about it a lot in the quality payment program for 2017 because with the CMS flexibility that came with the final rule, there actually won't be any data reported through Physician Compare for this year because the program has been reduced so much. But future years, just be aware that whether you're in an APM or reporting solo, there will be the public reporting of data. Now that data could come in several different forms. It's hard to know exactly what it will look like, but it could include composite score, performance category measures that you chose, aggregate information, so that's the range of your composite scores and the performance category scores, and then looking at that utilization. Are you a high utilizer? Do you cost CMS and your patients a lot of money? So take all of those things into consideration. Patients are becoming very knowledgeable consumers. This obviously will be made public on the Physician Compare website, so patients will be able to see it. We've also heard some talk that this could be included. Now, I don't know, it's different between all different organizations, but it could be included in provider compensation calculations. It could be included in hiring practices, and it could be included just in general sort of maintenance of certification. So just be aware of those things as you think about how you perform and the measures you're selecting and all of those different elements. Some quick resources. So this top link is our website, the New England QAO's MACRA page. We have an Ask a Question link. So if you don't want to ask a question now, either in chat or over the phone, please feel free to send us an email. The next link is the CMS QPP website. We listed the Mass Health and Hospital Association's website. They have a lot of resources as well. The CMS Quality Payment Program Year 2 proposed rule was released in June. That's the full document if you're interested in reading it. We will jump to questions. Those are my 3 dogs. I love dogs. And I think Morgan's going to jump on and just tell you about the evaluation before anyone jumps off. If you don't mind just completing that, that would be great.
So to complete the evaluation, in the bottom right corner of your screen, you'll see a word that says evaluation. If you click on that and then click the button browse to, the evaluation will pop up on your computer. So if you could fill that out before you jump off. If you did want to ask a question, as Leela's mentioned, you can put your question in chat, or you can ask your question over the phone. All you have to do is press #6 to unmute your phone and ask your question.
Leela, this is Steve FSA. Hi, Leela, this is Steve FSA. What a wonderful presentation you've given, and so much detail in ways that I haven't thought about macrometrics before. So I just want to thank you for this.
Thank you, Steve. I'm glad you were able to join us, and it was wonderful having the opportunity to share all of this pretty dense information with everyone.
While people are thinking about submitting their questions online or on the phone, I might ask you, that was a little, I could use a little clarification on those doctors who might be on paper charts. You had mentioned that you should know your non-reporters and how to report on them. Can you throw a little color on that for me?
Yeah, absolutely. That's a great question. So there are still obviously practices and clinicians still using paper. So in terms of quality, there really isn't a drawback to that. I mean, I would say really everyone nowadays should be trying to move towards the implementation of an electronic health record. It helps with interoperability and the transition of documentation across different clinical settings. But clinicians that are on paper for quality, if they have attributed patients and they need to pull any of those quality measures I've mentioned, the APM would just reach out to them and say, we have this handful of patients on these specific measures. Can you provide us whether you met the requirement? Let's say it was for breast cancer screening. So they give, the APM has maybe 4 patients assigned to that practice. Did you perform a mammogram or order a mammogram on any of these patients? And the practice would have to look through their paper charts and say, yes, on these dates, we saw the patient and we ordered the mammogram. Now, for advancing care information, since that is strictly electronic health record reporting, that practice would just get a 0 for that category. And then improvement activities, they would get full credit. So, and again, all of the participants across the APM receive the same score. So paper chart, electronic chart, you're all getting the same score.
Thanks, it's very helpful, Leila.
Again, if you have questions and you don't want to answer them or ask them, over chat or the phone line, please feel free to send us an email. I'll go to the next slide, my email. You can shoot me one directly. Happy to help you out. Our goal at the New England QuintQIO, as well as Steve's group at MHA, the whole goal is that we ensure that all the clinicians across Massachusetts, whether you're reporting under the MIPS program or through an APM, that you have the tools and resources needed to be successful. We really don't want anyone to get a penalty this year because the requirements have been reduced so much that we are here to help you. So please reach out. Again, we want to make sure you're successful. So
Bye, everyone. Thank you for joining. Thank you, Leila, for that great presentation.